guidelines state that we should treat our patients to achieve low disease activity of remission. However, the goal of low disease activity and remission are not very well known by the patients. In fact, when we surveyed a group of patients to see how much they know about treating to target, we discovered that about 50% of them are not aware of the treat to target strategy in rheumatoid arthritis. And I think part of it is because physicians haven't done a very good job in popularizing the concept of treat to target over the last decade, as this paradigm in rheumatoid arthritis treatment has become more popular and more available for physicians. So what we wanted to do is we wanted to figure out why patients are not treated to target, why the evidence-based guidelines are not followed. And what we found out by surveying patients is that there are many barriers to treating to target from both the physicians and patient perspective. And one of these barriers is medication risk aversion that the patients have. So to address this problem, we developed an intervention, an educational behavior intervention that included 6 videos that explained what treat to target is, explain concepts of shared decision making, inflammation, and damage in rheumatoid arthritis, to try to make it more down to earth for everyone to understand. And we used the animation in these videos, and we tested this intervention by comparing it or by deploying it in a group of patients with self-reported rheumatoid arthritis, and comparing with an intervention that intervention that contained videos talking about vaccination. And our primary outcome for the study was willingness to change therapy using a validated scale, the choice predisposition scale. And what we found is that in the patients that were exposed to the video intervention online, they were more likely to be willing to change therapy should their rheumatologist or provider ask them to. So while the change was quite small, it is important because that's just the first step as we try to make patients, or try to encourage patients to take action. So what the next study would be is to see if we can move from the pilot feasibility study that we've done into a clinical trial where we use multiple sites and deploy a similar intervention. The other goal of this project is to have this intervention scaled up. So sort of partner with rheumatology organizations and patient organizations to promote this program. In my ideal world, the program would be viewed by patients in rheumatology offices as they wait for their appointment. Our end goal is to improve outcomes in rheumatoid arthritis, so get people to be able to achieve their goal. And from a physician perspective, we talk a lot about disease activity and remission measured by validated tools such as clinical disease activity index or simplified disease activity index. However, I think we have to have a conversation with patients where we ask what their goals are, whether it is to be able to play golf with friends or tie their grandchild's shoelaces. These are important goals, and they can be measured, and they can serve as a goal for treatment with escalating therapy, for example. So eventually, in a clinical trial, one could look at patients that have a certain level of disease activity and expose them or offer them this behavior intervention, and seeing whether this intervention in combination with a physician intervention, perhaps like something like a continuing medical education or something like that, would be able to move the needle and improve disease activity itself. So sort of moving from the wish, the willingness into action.